differences. And that is why we've chosen this webinar to discuss not only the technique, but also how to bail out or troubleshooting in complicated cases, and also a fairly common problem of mucocele of the appendix and decision making in mucocele, and the further therapy in case of mucocele. Dr. Neena Shah, would you like to say something? Dr. Neena Shah, madam, is our president of the Association of Ahmedabad Surgeons, and she is very active in resident teaching and training. In fact, the association has taken keen interest in resident teaching and conducts programs regularly, webinars, seminars, journal clubs for resident teaching, which is really remarkable, commendable that they take this keen interest. I doubt whether any other association would be so active, specifically in resident teaching. And I was specifically instructed or told to keep topics of general interest, such that the residents also can learn from the basics from the masters in the field. Dr. Neena ma'am, would you like to add something?
Yes, good morning, everyone. I welcome all the faculties and members of Association of Ahmedabad Surgeons and our beloved residents also. As appendicitis is the commonest complications of the surgical aspect, and as per the history, the first appendicectomy was done through the scrotal route. By draining the scrotal abscess, the surgeon found out there was a perforated appendix and he removed the appendix. And after the name of this surgeon, it is known as a Emirard's hernia. And when we find out appendix into the hernial sac, we say it is a Emirard's hernia, just a part of history. I welcome Dr. Prabol Niyogi. He is a professor of surgery at MLN Medical College, Allahabad. He is, in spite of professor, he is a good teacher. He is always, I feel very happy to invite him because he remained present so many times in our association program on PG students teaching program. Also, he has been trained at prestigious institute like AIMS and in UK, where he was awarded as FRCS. He is a pioneer in the laparoscopic surgery in East UP and has several publications, accolades, and awards to his credit. He will discuss the technique of safe laparoscopic appendicectomy and criteria for open convention, because we are worried about the perforated appendix and the gangrenous appendix mainly. So I welcome Dr. Prabol Niyogi. I also welcome Ashwin Telangarwalu and Dr. Aditi Bhatt also. Welcome everyone.
Yeah, so for this meeting, sorry to interrupt Dr. Prabol. We have Dr. Neena Shah, who just spoke and introduced the speaker, and Dr. Daivat Vaishnav as chairperson. Dr. Daivat Vaishnav is a dear friend and colleague. He's a consultant surgical gastroenterologist trained at Lakeshore Hospital. He's currently practicing in Zydus Hospital, and he'll be co-chairing the session with Dr. Neena Shah. Dr. Prabol, please.
Yeah, good morning, everybody. It's a pleasure to be with the Ahmedabad Surgeons Association, and I congratulate you all for doing a great teaching program that you do very frequently. And I have, as Dr. Neena rightly said, I have been on your programs a few times before, and I found them very useful. I'll try and share the screen, and then we can maybe start.
Yes, it is seen.
Yes. Yes, now I thank you all for Ahmedabad Surgeons Association and Dr. Pankaj Modi, Dr. Rashesh for this opportunity. Greetings from Allahabad, now called Prayagraj. We are in the middle of the Magh Mela that's going on. Every 12 years we have the Kumbh Mela, and it's a huge congregation of the spiritual heads of the country. Just like in the Ahmedabad Surgeons Association, you have a Kumbh of so many great surgeons from all over India. I saw your program last month on safe laparoscopic cholecystectomy, and I appreciate that you guys are picking up those topics which of a common interest and which most surgeons do everyday practice. When I got a call from my friend Dr. Pankaj Modi and Dr. Rashesh a month ago, asking me to speak about appendicitis and safe laparoscopic appendicectomy, I thought it would be a dull rehash of what was already in the surgical textbooks. Was there enough material to suffice an entire Sunday morning discussing a mundane yet a very common and burning problem that we face every day? However, when I started serious introspection and looking at the various aspects of appendicular disease, I realized that our standard textbooks do not do justice to the important small nuances and the debates that surround this common problem. All these textbooks that are there, and probably appendicular disease is not as glamorous enough to merit attention in surgical texts, in conferences, and now in webinars. I hardly know a few webinars that have been conducted purely on appendicitis. And I congratulate the surgeons of Ahmedabad to be thoughtful enough to bring this topic up for discussion. I hope I, with my colleagues, Dr. Ashwin and Dr. Aditi, will be able to highlight a relatively ignored topic and also sound a cautionary note against trivialization of appendicectomy, whether open or laparoscopic. See these horrible consequences of appendicectomy which has gone wrong. So I would pray to our residents that do not trivialize appendicectomy. The consequences are really poor. Liana, I'll just give a brief introduction of appendicitis, and then we'll go on to safe appendicectomy in an uncomplicated appendix. That's what I'm supposed to speak on. Leonardo da Vinci in 1492 was the first. 1492, can you imagine that time, that's as early as 1492, first gave us medical illustrations of how an appendix looks like in drawings. Of course, they were published much later in the 18th century, but over here in the drawings, they show appendix as a vestigial structure. But actually, is appendix a vestigial structure? We do not know. So honestly, the answer is that still we do not know. The mystery of the appendix is still not being unraveled. Should we take a normal appendix out? That is, it has been seen that the appendix actually, I did a bit of reading and I saw that the appendix has actually developed in primates, in the old world monkeys. If you take the Darwin's evolution, it has actually developed further. And in fact, in primates, it's probably progressively it has developed. So should a normal appendix be removed as part of another operation, which is a very hackneyed topic, like people often at some point of time for a hysterectomy, they could do a appendicectomy along with a cholecystectomy. They do an appendicectomy without basically taking a normal appendix out. But the answer, the evidence of literature suggests that that should not be done. If when you're doing it as part of another operation, it should not be done. But what if it is a misdiagnosis? Of course, if there is a right iliac fossa pain and there is a misdiagnosis, then when there is no other pathology found or no explanatory pathology, then probably you are justified in taking out even a normal looking appendix, because often it has been seen by histopathological examination that there has been inflammation, and so that you can get that that much of leverage is allowed. The caution too is, of course, there are some anatomical variations which are very rare of duplication of appendix, and mimic carcinomas, colonic carcinomas, and of course left-sided appendicectomies. Of course, then be sure of your diagnosis. Now, I do not want to go into details about how you diagnose an appendicitis. That's all of you know about clinically. It's what many scoring systems are there with Alvarado scores and other scores. But ultrasound, of course, it is an extension of the clinical examination, as you all know. And the sensitivity and the specificity of picking up an appendix, the sensitivity is around 75% and the specificity is around 85%. Unfortunately, it is heavily operator dependent. Of course, you know that the diameter of appendix of more than 6 millimeter, pain with compression in the right iliac fossa, presence of an appendicololith, then periappendicular fluid, and echogenicity of fat, of course, guides you that it is likely to be an appendicitis. But as a CT scan, the sensitivity and specificity reach about 95%. So, of course, to confirm a diagnosis, you may have to resort to a CT scan. But unfortunately, you have this radiation exposure risk. And in children and in men, it is now suggested in young ladies, it is of women of reproductive age group, it is recommended to do a laparoscopic, diagnostic laparoscopy for this subgroup. And now it is been confirmed by from the guidelines of the European Association of Endoscopic Surgeons that diagnostic laparoscopy should be done in this group. And if no other pathology is found, you could do appendicectomy. And this, of course, was confirmed by a large Cochrane study recently as well. Radiology, I don't want to go into details, but I'm going straight on to the surgical techniques. Our thanks to this man, Kurt Sen. He performed the first laparoscopic appendicectomy in 1980. He was a genius. He developed many laparoscopic instruments that we are still using today. And in fact, the one in the corner that you see, the corner image of insufflator, that's the VISAP insufflator. And this is the man who invented that. And I have used this VISAP insufflator some 25 years ago when we started doing laparoscopic surgery. This was the insufflator that used to be used, VISAP. And if you remember the older surgeons who are here, we used to use insufflator from Worm and VISAP. And this is the man who actually invented this. But did he get recognition for doing the first laparoscopic appendicectomy? No. His claim of doing an appendicectomy when he used endo clips and monopolar cautery, his article was rejected by the American College of Gynecologists, saying that this procedure was unethical. In fact, they went further on and his license was taken out. His license was taken away and medical practice. And he had to face the ignominy of getting a CT scan of the brain to see that is he in his senses? Is there something wrong in his brain that he has come up with such a stupid paper? So dear friends, this is the beginning of laparoscopic appendicectomy. The patient selection, of course, it does not, it is totally, whatever you do for open appendicectomy, the patient selection is the same. For uncomplicated appendicectomy, you can undergo a laparoscopic appendicectomy. Controversies are there in the complicated appendix, where it's gangrenous or the perforated ones, or an appendicular abscess. And I think Dr. Ashwin and Dr. Aditi will take you further on that. Of course, patients who are unfit for GA or critically ill for secondary peritonitis, when you have to save time, probably we could go in for an open surgery. And of course, if there is a suspicion of malignancy. Laparoscopic versus open, now there is hardly any doubt that laparoscopic appendicectomy is a better option than open. So all the trainees out there, you have to learn this procedure because now it's been proven by literature as well. In the first study from the World Journal of Emergency Surgery, about 600 patients, they found out that, of course, the stay, I'm just repeating it, that is the stay was short, there was less analgesia required. The operating time was more in laparoscopic than in open. And the total complications were less in laparoscopic as compared to open. And it was corroborated in the study, which is down there in the lower part of the slide. In this, 45,000 appendicectomies were seen, and they found that laparoscopic appendicectomy had a significant advantage over open. Why is it important to choose lap appendix and open appendicectomy when you can do both? You have to choose your cases, because it has been seen that the conversion appendicectomy, there's another third term which has come up, is a conversion appendicectomy, which you have to convert from laparoscopic to open. And it is seen that in a cohort of more than 279,000 patients studied, and it was seen that the conversion appendicectomy had the worst outcomes, and these outcomes were even worse than doing an open appendicectomy. And these, in terms of infectious and inflammatory complications, renal complications, and hematological complications. So these are the study that was done. It's a huge study. So how do you choose? There have been many prediction scores. I'm not going into details of that. Unfortunately, there's no prediction score right now, which is, and somebody can take this up as a research topic actually, because they have given points for appendicular abscess and for generalized peritonitis. Other criteria for sex, race, and BMI have been taken into account. But of course, it's wise to do a diagnostic laparoscopy first with a fair amount of clinical skills, surgical skills, and good energy devices, I repeat, and a careful handling of adhesions. And of course, getting the appendicular base, a safe procedure, safe laparoscopic appendicectomy can be accomplished. Pre-op preparation is very similar to open appendicectomy. Of course, always take an informed consent for open. IV antibiotics, my choice is to give a cephalosporin, a second-generation cephalosporin with the metronidazole. Empty the bladder. Often we forget, the nursing staff, we empty the bladder. And especially in women, I prefer to put a catheter for the duration of surgery. Often because if there is not an appendicitis, the misdiagnosis, it facilitates visualization of the pelvic organs and makes surgery easier. Theater setup, nothing much in the theater setup. It's that you have to be on the left side of the patient, the cameraman to your right, the assistant on the right side of the patient. Of course, you can see the cameraman bending his neck to see it. If you are rich enough, you can get another monitor for the assistant and put it on the other side. If you want to save your assistant's neck. But we being poor countries, we probably just have one monitor to look at. Then the instruments that are used, common instruments that will be used are the one 10 mm trocar, then two 5 mm trocars are usually used. You have a needle holder, you have bowel holding graspers, you should always take. You need two telescopes, one a 10 mm telescope and one a 5 mm telescope. Now, if you do not have a 5 mm scope, then in that case, you can make two 10 mm ports, one at the supra-umbilical port, can be another 10 mm port, so that you can take the appendix out through that. But if you have the luxury of 5 mm scope, you can change scopes, and I'll show you later on how we do it. Energy devices, monopolar cautery is commonly used. That is the most widely available. But I would suggest a bipolar cautery for beginners. And if you have the luxury again, harmonic. I use a harmonic, and it makes life much easier. The position of trocars. Now we have various ways in which you can position your trocar. One way is to put the 10 mm scope, the camera port through the umbilicus. This is the right iliac fossa. Put one at the supraumbilical port and the other in the right hypochondrium, so that you get a V configuration and a diamond shape that comes out, and the appendix is somewhere here. So you can do that. But I'll tell you the problems with that. The commonly used classical way is to put the 10 mm scope through the umbilicus and the two 5 mm ports, one at the supraumbilical port and the other in the left iliac fossa. Now, if suppose you do not have a 5 mm scope, what you can do is that you can change this 5 mm port into a 10 mm port. So that the extraction of the appendix can be done through this port, either of the 10 mm ports. I recently had a trainee from down south, and where Ashwin probably would tell us more about it from the GEM hospital, and they were using a 5 port in the right iliac fossa. Am I right, Dr. Ashwin?
Yeah, that's correct.
Yeah, they use a port at the 5 port, and but I find that I don't know. It's I've never done that, so I cannot comment on it. When you have the position of the ports in this position, that is the V configuration. For beginners, it might be easy to do the appendix because you have the classical V-shaped configuration. But unfortunately, what happens here? Follow the picture down. Your cameraman, see the cameraman's hand. It comes from below your arm. Your arms are crossing, and it is right in your axilla. You might feel ticklish if your assistant is a bit fidgety. Whereas if you get the other position in which you have the 5 ports, one of the suprapubic and the left iliac fossa, you get a configuration like this when your cameraman is comfortably standing towards the head of the patient, and there is no crossing of arms. You can see this, the other one in which the arms go below the patient, and the surgeon has to cross his hands while doing it. So preferably this method is, once you get a bit of experience, probably this is a better port position. Position of the patient and trocars. I have just told you about that. Now you see, I'll tell you what is the difference between when the instruments come in, how they come in. This, I think, is the classical V configuration when the cameraman's hand is crossing the thing. So if you see, just a minute. Yeah. Can you see the video?
Yes.
Yes, but it is playing slightly slowly.
Yeah. So sorry.
It's playing little slowly.
Yeah, I know it's playing slowly. I wonder why that is. How do we get the speed up? See, basically the left-hand instrument comes from the left side, and can I increase the speed of this? Anyway, anybody knows, and the right-hand port comes from the top. So that again is the classical V configuration, and it makes life slightly easier. I am not able to get the whole video. Anyway, the other video is not working.
You can go out of the presentation and play. Maybe that will help.
Let me see. Right, and this is I don't know. There's something wrong with the videos. This is the other position in which the hands are both from on the suprapubic and the left iliac fossa. So this was patient who had an open appendicectomy, and there was the patient presented with obstruction, and you could find that the appendix was not taken out. So this was we were doing basically for this. I'm just showing you the port positions. The port positions on the second was basically when it comes up from the supra pubic port and on the left iliac fossa. The next thing is to identify and localize the appendix. You can just simply retract the appendix and follow the tinea, as in the classical way. If it's a retrocecal appendix, the lateral peritoneum has to be divided and extended medially according to the mesenteric attachment. And for a retroileal Trendelenburg position, you have to displace the bowel cranially. I hope this video plays. I think some videos, the complete video is not coming actually.
It is seen.
I know it's seen, but the whole video is not getting shown. Anyway, so that's basically following the tinea. You follow the tinea right there, and as soon as you see the tinea, you can see the base of the appendix. You can pick it up with your graspers on the right side, and with the left do the dissection. If you cannot, yeah, and this is another case in which the appendix was retrocecal. So you take off the adhesions from the lateral part and find the tinea, keep going down, find the tinea, and as soon as you reach the end of the tinea, you'll get to the appendix. I am not able to move this fast. Right. So this is basically the appendix on the right iliac fossa, which is retrocecal. And when you move these adhesions, you will be able to find the appendix. And of course, with gentle teasing of the tissue, you will be able to get to the base. Another case, interval appendicectomy. Something wrong with the videos. Anyway, this is another case in which basically to find the appendix, you have to take off these adhesions and take the patient in a left lateral tilt and do a Trendelenburg position and take off the lateral dissection. I'm sorry, I'm not when the videos are not working well. Anyway, these are coming. You can see these. So I'll just flick off from here. Now, next thing is to control of the mesoappendix. Now, there are two ways to tackle it. Either you stay close to the appendix, starting from the tip, going towards the base. So that if you go in this plane, so what you will get here is get these small vessels, which you can ligate by monopolar or by harmonic. And the other way is to go in from here, catch the throat and of the appendicular artery, and then move on here. The advantage in the first thing is that you are skeletonizing the appendix, and the extraction of the appendix becomes easier. So you start with your harmonic from here or your monopolar and keep going along the appendix, and that would make the appendix free of the fat, and the appendix can come out. Extraction would be easier. For the energy sources, a monopolar, bipolar, harmonic, anything can be used. Vessel sealer, of course, is I think an overkill. Don't need a vessel sealer for this. And normally, if you do a monopolar, you use the monopolar dissector, keep going down, and the bipolar, of course, to keep buzzing off and then cutting it with the scissors. Control of the mesoappendix, there have been various methods in literature. There is not much difference between the various methods of dealing with the mesoappendix. They found out in a large study whether any of these methods by monopolar is better than harmonic. They found that there is not much difference in the primary outcomes. Of course, using a harmonic scalpel reduces the operating time. The control of mesoappendix. I'm not able to get the whole video. It comes in parts actually. Not sure how it's not working properly. This always happens on the final day, and it just.
No, but sir, it is very well
there, ma'am, but the whole video is not coming. It's half the video.
Yes, but whatever is seen, it is excellent videos.
Yeah,
we are able to see it properly. Whatever you are speaking
right. So that is. So the idea is to catch hold of the appendix and move your. Keep changing your hands and. Keep changing your hands. With this, you're holding it down, up, down, and then finally, as you go down, you keep moving your left hand down and use the monopolar or the harmonic as you go down the appendix. In this, it's been shown we are not going through the tip. We are holding a hold of the marginal artery first, and then going down. But we have to be very careful of at this point when you see the V of the cecum coming in the picture. Use of energy sources have to be limited here, and you have to be very careful that you do not injure the cecal wall at this point. That's another one, another of the videos. The same thing, you can. It's a bad appendix. It's a acute appendicitis, and you can see the adhesions. And as you move down, your left hand moves down, and with the right hand keep going down as you hold the appendix. This is an important part where you where you see the cecal wall and the appendix coming out. That area has to be cleared, and so do not leave a stump of the appendix, and on the other hand, do not injure the cecal wall as well. These are all bad cases. This is the control of the mesoappendix, again in a acutely inflamed appendicular lump. This is the whole thing did not play. That's the second step. After finding the appendix and mobilizing it, the next thing is to control the mesoappendix. Often it becomes difficult in acutely inflamed patients, but with a lot of bit of patience and with good surgical skills and with a good energy source, you'll be able to do that. Now, next thing is to control the appendicular base and excision. Now, pre-tied endoloops are used. I often don't use them. I do an intracorporeal suturing. You can do it singly or doubly inflamed. In case of an acutely inflamed appendix, the first stitch that you take, the first knot that you take, the first tie that you take should not be too tight, otherwise it might cut through. Most of the times we have seen that the base of the appendix is healthy. You do get a stump which is healthy. Despite it being a gangrenous appendix, you can get a small stump of the appendix from which you can work. And of course, if in doubt, if you cannot get to the base of the appendix, you can convert or use a GIA stapler. That is the closure of the appendix. It's been seen a large study again comparing endoloop with other techniques of doing it. And this large study done was about 850 patients who compared using titanium clips, ligature, and endostapling devices. And it was found that there was no difference in the total complication rates between the ligature and using any type of mechanical device like a stapler. However, in the analysis of secondary outcomes, it revealed that the use of mechanical devices saved approximately 9 minutes of your time. And but of course, the conclusion was that there is evidence is insufficient at present to advocate the omission of conventional ligature-based appendicular stump closure in favor of any single type of mechanical device. And for the ligation of the base appendix, I usually do it with the endosuturing, where you get to the basically base of the appendix. I do not use endoloops because and also for PGs, you should practice your tying skills, the suture tying skills, and that is probably very important. In fact, now a lot of people are recommending even to tie the cystic duct instead of using clips. If you remember, there has been a litigation of a huge amount of litigation when the clip migrated into the common bile duct. So, where's my cursor? So of course, I think you tie it at the base of the appendix. Make sure that you do not take the cecum along with it. The other tie is put in, the second tie. I usually put just one tie proximally and one tie distally. You can cut the threads. You tie it with Vicryl, and you can of course cut in between the two. Retrograde lap, you have to do, sometimes you have to do this. In this patient was in fact a doctor. She was an anesthetist, and she came with a mucocele of the appendix, and it was a hugely dilated and distended appendix. And of course, you dissecting it further, what you could get to is the base of the appendix. So if you could get to the base of the appendix, give it a tie. Once you've tied this, you can then do a retrograde excision, and this came out to be a mucoepidermoid tumor of the appendix in this case. Of course, we will discuss that later on. I think our other speakers will discuss what to do in such cases. But in this retrograde, you should know how to do a retrograde appendectomy, where you tie the base of the appendix first and then go on and dissect the mesoappendix. Extraction of specimen. Extraction of specimen is, as I said, when you take the mesoappendix, if you stay close to the appendix, the extraction appendix becomes easy. You change your scopes. You change your 10 mm scope has been taken out, and a 5 mm scope will. Video is running very slow. I don't know. It's not showing the whole thing. Just a minute. I'm sorry about this. The whole video is not showing, and just part of the video is showing, and it's showing very slowly. I'm not sure what the problem is. You change your hands. You put the 5 mm port, 5 mm scope through the supraumbilical, and take the appendix out from the 10 mm port. That is the 10 mm trocar, the claw forceps going in from the 10 mm port. I'm sorry about this. And you get the appendix out, you put it inside the trocar. The appendix has to go right. The appendix has to go right inside the trocar. I mean, yeah, that's it. You have the appendix has to go right inside the trocar when you take it out, so that it has to go right inside the trocar. And once it's right inside, then you can pull your specimen out. Extraction can be done by using inside the 10 mm port. You can also use endo bags and various modifications of endo bags. When you have a very bad appendix with pus around, an endo bag probably is a better idea to use an endo bag. It does not cause infection. Extraction of specimens. Sometimes you get these types of specimens. We will again discuss that later on. When you get basically the specimen was opened up and a tumor of the appendix was found. We will talk about that later on. Other speakers will talk what to do in this case. And in these cases, of course, you see the margin. If the margin is not clear, then you would have to go in again and maybe do a right embolectomy. And if you have a clear margin of about 5 millimeters, you can wait and watch and put the patient on follow-up. After extraction, you cauterize the stump, do a peritoneal toilet. Bowel inspection, do not forget to do a bowel inspection, just like an open appendicectomy. Of a meter of the terminal ileum is seen. Drain, in case of an appendical abscess, you put the drain. I always use a PVC tube. I do not use a Ride's tube, because Ride's tube sometimes, more often than not, gets blocked. And if you actually need a drain, it does not drain. So maybe a PVC drain is better. For single incision laparoscopic surgery, sills, I am not a proponent of single incision. I do not find any advantage in doing sills, but that is totally my personal experience. It is, in literature, it is shown that sills does show promise of improving postoperative recovery and prospective results. Those people who are doing sills, but I do not do sills because I do not think it's a very physiological and a safe way to do an appendicectomy. Despite being safe, you can get visceral and vascular injuries, you can get iatrogenic bowel injuries, cecal burns, and something interesting called the Douglas syndrome. Now, Douglas syndrome is an interesting syndrome which was first reported by Mr. Douglas. And what he said, he often after in post-appendicectomy patients, you still find a pain in the right iliac fossa and with a little bit of total leukocyte count high. Now, despite getting ultrasounds, there was no collection seen and there is nothing there. So they found out that if you, probably this Douglas syndrome is because if you leave a long stump of appendix and that stump gets necrosed, so you can get this Douglas syndrome. It is often a self-limiting condition. It often self-limits, but if it does not, then you might have to go in again. Post-operative abscess, stump leaks, and wound infection, bowel obstruction are similar to open appendicectomy. So safety is the key. You don't need to know the whole alphabets of safety. Simply the ABC of safe laparoscopic surgery is always be careful. Thank you. I'm sorry, unfortunately my videos actually they did
That's
not
okay.
work.
That's okay, Dr. Prabal. We enjoyed your talk, and you drove home all the take-home messages quite well. And
Yes.
I now invite Dr. Daivat Vaishnav to introduce the next speaker. We will have the questions at the end. Is that okay, Diana?
Yeah, we will have a question at the end.
Questions at the end so that we have enough time for the discussion and the flow is not interrupted. Dr. Daivat, please introduce Dr. Ashwin.
Yeah, good morning, respected seniors and my dear colleagues in the AS. Today we have privilege to have Dr. Ashwin Thangavelu. He is the consultant at the Ashwin Hospital, Coimbatore, and he's a very skillful demonstrator of laparoscopic videos at various academic sections, as well as his videos on YouTube also are quite popular. And today we will discuss the safe laparoscopic appendicectomy in the complicated appendicitis. So I will request him to take this screen.
Thank you very much, sir, for the kind invitation. First of all, I'd like to thank the Ahmedabad Surgeons Association for this kind invite. So we all know that laparoscopic appendicectomy is considered as a very simple procedure, and that is the first procedure which a lot of the surgeons would get to perform as well, immaterial of whether it being open or laparoscopy. So here in my talk, I'm going to show you various problems which a surgeon would face in his career, and we should not take this condition very lightly, and we should be with a very good open mind and a good backup and a team as well to perform all these advanced procedures. So with that, I'll just dwell into my video. So my talk is going to be safe techniques to perform in difficult laparoscopic appendectomies. So is my pointer visible to you all?
Yes, it is.
Okay, cool. So this is the standard port position which I would use in a laparoscopic appendicectomy. So there will be one 10 mm port in the camera, a 5 mm port in the left iliac fossa, and a 5 mm port in the suprapubic region. The idea of using this port is it gives you a good triangulation, and it is a little away from the target organ as well. If at all there is a small early inflammatory mass, then I would make this as a 5 mm working port, and I will convert the left iliac fossa into a 10 mm port. That way the distance from the target organ is even more increased, so that we have a good triangulation and a good visibility of the organ as well. Whereas in patients where I know that there is going to be some amount of difficulty, and I anticipate that we are going to have a little more challenging situation, then you can see my port configuration would vary like this. So here we would find the base of the appendix. So I put the camera port in line with the base, but much farther away from the umbilicus. So the key in any laparoscopic surgery is to have a good distance from the target organ. So that will not hinder our vision, and we can have a nice panoramic view whenever required. Otherwise, we will tend to struggle. And you can see the right working port and the left working port are made in a similar line, at least 8 centimeters away from the camera port, so that we have a good triangulation, and we can even do a intracorporeal suturing easily whenever required. So these are some subtle variations, but very, very important to make sure that the surgery is very smooth, without much of a difficulty. So these are some difficult scenarios. Here you can see the tip is located in the pelvis and a lot of pus and inflammatory collection in the pouch
Dr.
of
Ashwin,
bile. Yes,
Dr.
sir.
Ashwin, we aren't able to view the video. Have you started the video? We just watching the port image.
Okay, 1 second, sir. I'll just share the screen again.
Yeah. Dr. Priya, can you help?
Is the screen visible now?
Yeah, it is visible now. Yes. Please go ahead.
Is the video playing?
Video is not playing. The image is visible.
Even now it's not playing, sir?
No.
No.
Okay, sorry about that.
I think you can click in the lower part. Yeah. It started and again stopped.
Oh, all right, ma'am.
Would it be better if you came out of the presentation and exited the presentation and played it from your file, played the file?
Yes, I'm actually doing that only. So let's hope at least it's playing now.
No, it isn't playing. Your presentation has started.
Has the port slides come in now?
Yes.
Okay, sir. It's actually integrated in a video format. I don't have a PPT. So I think it'll just keep moving. We'll just hope that it goes on without any problem. Is the video coming in now, sir?
No, the video isn't coming. No.
Sir, you
not
can
yet.
try playing the video from your desktop, from the source file.
Yeah,
From where
I'm
you
already
would
doing
have
that only. I don't know what the problem is.
Starting and then stopping.
Oh, all right, sir.
It's jerky.
Okay.
Okay, that's better now. It is slightly better now.
Okay.
Yeah, it's playing now.
Yes.
So sometimes the appendix might be in a challenging position, or you can see here it is a very short appendix. You can already see the cecum without much of a space available for us to do a dissection and apply an endoloop. You can see the entire length of the appendix is very short. So this is a short and stout appendix which we would encounter. So these are some of the difficult situations and presentations which we might have in our day-to-day practice. But we can easily get over them without much of a problem.
Again stopped, I think.
Yeah, the video doesn't continue to play.
Okay. Even now it stopped, is it, sir?
No, it is not playing. Yeah,
Yes,
now it is playing.
Okay. For me, because it just continues to play, I don't know what the issue is.
It is playing now.
Playing
You can,
now.
yeah, you can
Carry on.
continue to speak, sir, as it is playing.
Okay.
No, again it went back, I think.
It's still not playing, sir?
No, it is not playing. It played for a while and then stopped. Yeah, I think
Okay.
it went back again.
It's still
yeah, now it is playing.
Okay.
No, it stopped.
So could you just ask the next presenter to start with the topic? I'll just
I will
upload the
check
video
if
to a
it is
YouTube and
ready.
probably share the link to the host. That way it might be easier.
I will check whether she has joined in because she was supposed to join. Yeah, she has joined.
Okay.
She has joined, I think so.
Dr. Aditi, are you there? Dr. Aditi? Priya, please make Dr. Aditi co-host.
Yes, sir.
Dr. Aditi?
Priya, call Aditi for the.
I'm calling.
Yeah.
So she is starting a presentation in a while. Meanwhile, we can start with the questions if there are any. I have one question for Dr. Prabal Niyogi, if he is still there. I believe he's not left the meeting.
Yeah, I'm there.
Yeah.
Yeah.
So, sir, when we were undergraduates, there was this Oshner-Sheren regime, for acute appendicitis. If I remember correctly, it was for appendicular lumps, for expectant or conservative management of appendicular lumps beyond 72 hours or 96 hours. When it was deemed that dissection of the appendix is not safe and it would cause hydrodynamic damage to maybe the cecum or small intestine. What is the current status of this regime, sir?
Often, yes, you're right. In some textbooks now, like especially in Mango's textbook of abdominal surgeries, what they have said that even if it's an appendicular lump, you go in. Like you can do an appendicectomy at any time. But unfortunately, we do not, like the evidence of literature still does not suggest that. If you have an appendicular lump, I think it is better to wait and give a conservative treatment, unless it is an abscess in which you have to, and the patient is very sick and the septicemia, and of course you have to drain the abscess, and maybe not only just drain the abscess and come out of it, and maybe do a appendicectomy at a later date. And Oshner-Sheren regime is still being followed, and I think it is the right way. If you have an appendicular lump, and you should give it a conservative try and wait for things to settle down before you enter. And first, if it is an abscess and things are getting bad, like tachycardia, raised counts, patient is getting pain, signs of sepsis are there, then you'll have to drain the abscess. Maybe a percutaneous drainage is enough, actually.
Yeah, my concern with this regime is that you may miss some serious pathologies like cecum, cecal mass malignancy, or maybe Crohn's disease, although Crohn's does not always require surgery. But malignancy, we all know that clinical examination can be fallacious, and they have overlapping findings. So I would actually, be very skeptical or very cautioned before I subject the patient to, unless I am very sure that it's an appendicular abscess on CT, I will not follow this regime. Meanwhile, Dr. Aditi is ready with her presentation. Dr. Priya, can you make her the co-host so that she can share the screen?
Yes, sir, she's already co-host, sir.
She's already. Dr. Aditi, are you there with us now?
Yes, I'm there, but I'm not able to share my presentation.
Dr. Priya, can you look into this? Help her out.
There's no option of sharing my presentation when I.
There will be a green.
Share screen, all right. Yeah. And yes. Then I'm stuck. I'm not able to share the PPT.
Unfortunately, we are having a lot of glitches today.
I'm not able to. I'm stuck after that.
I know.
First tell Dr. Ashwin to exit from share screen.
Yeah, Dr. Ashwin.
Ashwin, you have to exit from share screen.
Dr. Ashwin, can you hear us?
I can hear you. I've already exited the screen.
Okay.
Okay.
So by that time, I have one more question for Dr. Prabal. If, as you said, there is a Douglas syndrome, how will you diagnose? That is the first thing.
Yes. If patient is persistently complaining of right iliac fossa pain, and after an appendicectomy, you get the routine tests. You get a CBC and you get an ultrasound to rule out any complications, like first see if there's any collection or any abscess around there. But Douglas syndrome is diagnosed only when there is nothing there. Absolutely, it's a clean bowel. Even on a CT scan, you find that there is nothing there, no collection, no this thing. So what they said that that could be.
But my presentation is not showing. I'm ready.
So Douglas syndrome is only diagnosed once you have ruled out a collection, and that could be because you have some people take two ligatures, one at the base and then another one proximal to the distal to that. So if the stump is long, that it seems can get necrosed and cause this syndrome. So the idea is to keep it to a minimum. If you take two sutures at the base of the appendix, the distance between them should not be more than 5 millimeter, 0.5 centimeters. And if it's a longer, then this syndrome has been seen to occur. So
Yeah, even abscess can occur in between these two stitches. Abscess can also occur in between
yes,
these two stitches.
exactly. So
Yeah.
Sir, can you take on Dr. Rase's concern? Because what I feel that age of presentation of appendicitis and CSCM are different. So
yes. Not only that, even the clinical presentation.
Clinical presentation.
So I think that is the importance, that where the importance of clinical examination and clinical history comes in.
Yes, sir.
A young patient who has typical symptoms of severe abdominal pain and acute appendicitis progressing into an appendicular lump, of course, you will not suspect a CSCM there. The problem comes, as Dr. Rashesh is, he's also right, that in a middle-aged patient, if that it comes, then it might be a diagnostic dilemma.
Oh.
So, Dr. Priya, can you help, or can someone help Dr. Aditi to share her screen? Meanwhile, Dr.
Now
Ashwin
we
is
can see her screen. So if she can try
okay.
sharing the presentation, because I can see that she's trying to email me the presentation.
Okay.
Ma'am, please try sharing your presentation now.
See,
Yeah,
Aditi,
now
I will like to introduce Aditi as my first resident. 20 years back, she was my first resident. She worked under me for 3 years.
Yeah.
Can you
Now-
hear me and can you see my presentation?
Yes, Dr. Aditi, we can see you. Dr. Daivat, please introduce Dr. Aditi.
As Nina madam rightly said, she was a first resident and now she is my colleague at Zydus Hospital. She has a special interest in GI, gynec and peritoneal surface oncology. And on her name now, she has many publications and we are seeing her day in, day out doing a very nice peritoneal surgery in next theater in Zydus Hospital. So I will request her to start up her presentation.
Okay. Thank you, Dr. Devat, and thank you, Dr. Rasesh, for the invitation. Hello, madam. It's a pleasure to see you after so many years.
Yes, you came back to hometown after so many years. Welcome you.
Yes.
Yeah.
So this is one of my favorite topics, and I'm happy to be speaking on it. Now I cannot run my presentation. All right. Okay. So normally these are the kind of tumors I treat. This is a huge PMP. There is disease on almost every peritoneal surface, and this is what the specimen looks like. The ovaries, uterus, appendix, right colon, rectum. This is the liver capsule. The spleen is here. This is another one, what we call a huge PMP. This is the specimen. And it's hard to believe that it all begins with something that looks so innocuous as this. So as you can guess, this is an appendix and it is ruptured at one point and is extruding mucin. So what term will you use for it? Will you call it a mucocele or a mucinous appendiceal neoplasm? I say it could be either. Mucocele is basically just a cavity filled with mucin. So if this is the appendix, there are two ways a mucocele can arise. The lumen gets blocked and the normally secreted mucin accumulates in the appendix, giving rise to a mucocele. Or there is a tumor leading to overproduction of mucin and giving rise to a mucocele. Now, most mucoceles are mucinous appendiceal neoplasms. Such retention cysts are uncommon. So when you see a mucocele, the first thought should be that of a malignancy. And retention cysts do not generally measure more than 2 centimeters in size. So mucocele is just a descriptive term. It is not a pathological diagnosis. Mucinous tumors of the appendix or mucinous appendiceal neoplasms are the second most common appendiceal tumors. Carcinoids are the most common. They are relatively rare, and 25% of them are adenocarcinomas. So all our interest in these mucinous appendiceal tumors is because they give rise to PMP or pseudomyxoma peritonei. How it happens, these tumors arise from the mucosal epithelium. There are two components, mucin and epithelium. And surprisingly, this mucin can be as notorious as the epithelium itself. The mucin and epithelium both grow within the lumen of the appendix, invade the wall, and finally extrude and produce PMP. Mucin itself can give rise to PMP. So it is certainly not a benign condition, it is a malignant condition. I created some case scenarios to go through the pathology and what should be done when you are encountered with a mucinous tumor. So the first is a case of a 28-year-old male who presents with pain in RIF. The CT scan shows an enlarged inflamed appendix, and the patient is taken up for laparoscopic appendectomy. This is what you find. This is not a laparoscopic procedure, but this is what the appendix looks like. Now you've removed this appendix, the base is clear. What will you do next? Post-operatively, you finish the surgery, remove the appendix. What next? Or rather, what would you do intra-op first? Will you do an appendicectomy alone? Will you sample the peritoneal fluid, do a peritoneal biopsy? Or you would directly go ahead with the right hemicolectomy? Because looking at the specimen, looking at the appendix, it seems to be malignant. Will you convert to open surgery or will you continue with laparoscopic surgery? Any thoughts on that? Any comments on that?
Yeah, so if the base is clear, there is no harm in doing finishing with an laparoscopic procedure, laparoscopic appendicectomy.
Correct.
And maybe utilize frozen section services, do a frozen and look at the, if possible, the grade of the tumor and the histology of the tumor.
Okay, and what, how will that, what will you do? Let's say it's high grade or it's low grade.
Yeah, so my current understanding is that if it's a low grade tumor and if the margins are free, you know, the procedure is sufficient. On the other hand, if it's a high grade tumor, if it's an invasive tumor, mucinous adenocarcinoma, then because there is a risk of lymph node metastases,
all right,
we need to extend it to oncological procedure like a right hemicolectomy.
So probably what you would do is continue with the laparoscopy. On a frozen, if it's high grade, you would proceed with the right hemicolectomy and maybe other peritoneal biopsies or cytology, right? The third option. What I would do perhaps is not base my decision on the frozen. And if you have the skills with laparoscopy, perhaps continue with the laparoscopy. So now you've done an appendectomy. Let's say you stop at the appendectomy, you do not have the frozen facilities, and you finish, take the biopsies. Now everything depends on what the pathology report says. So the pathology report says it's a low-grade mucinous appendiceal neoplasm or a LAM. The peritoneal fluid is negative. You've done an omental biopsy. It is negative for malignancy. So as I was asked to talk about pathology, I'll explain a little bit what LAM is. So this is the normal epithelium. This is not a normal epithelium, but normally the mucosal epithelium is cuboidal or columnar. What happens in these mucinous tumors is it looks very normal, but there is apical mucin. You can see the basement membrane is intact. These are the, it's just a diagrammatic representation, but the nuclei are basal the nucleoli are few, there are no mitosis, and this is what it looks like on pathology. It looks very regular, very organized. Somebody may call it benign, but there is apical mucin. Compare this with the frank adenocarcinoma. The cells nowhere look normal. They have bizarre nuclei, and there is no interface with the stroma. They are scattered in the stroma, and there is no intact basement membrane. So this is the typical feature of a LAM. There is pushing invasion. This is what we call pushing invasion, where the basement membrane is intact, it looks almost normal, and the cells also look benign. There are some diagnostic criteria for LAM. Most important, pushing invasion, dissection of acellular mucin and mucinin cells outside the appendix. So to cut it short, a LAM is cytologically a low-grade tumor with pushing invasion, but it can proliferate and produce peritoneal disease. It rarely produces distant metastasis. It is a malignant condition and not a benign tumor. So not many years ago, we used to get such reports, mucinous cystadenoma mucocele, as a pathological diagnosis. This is wrong. Whenever you are faced with an appendicectomy, a tumor intra-op, always get a pathology review. Most of the labs now in Ahmedabad give a correct pathological diagnosis. That is largely because the AJCC8 classification classifies these tumors correctly. This is what used to happen when the WHO classification was used. So if you got your pathology at a small lab, it is always better to get a review at a good reputed lab, and you will get a correct classification. It is most important because your subsequent treatment depends on what the pathology report says. So the other important thing that we have to understand is what is a perforated lamb and a non-perforated lamb. Now, if you look at this tumor, this looks intact. You would call it a non-perforated tumor. And this tumor looks perforated, mucin is coming out. So this is definitely a perforated tumor. But if you look at this tumor is also a perforated tumor. You cannot always tell on visual inspection. There will be cells and mucin on the surface. So to stamp the diagnosis of a perforated tumor, you need a pathological opinion. And this is important because all your subsequent treatment depends on whether it is a PT3 or a PT4. So what should be done next? Now you've resected the tumor. The pathology says it's a LAM. We always prefer to investigate these patients. So certainly not a PET scan for a mucinous tumor. I would still do a CT scan if it has been done before, because many times the CT done in emergency is done without giving proper contrast, or it is not evaluated properly. So it is always better to get a baseline CT scan. The preferred time would be 2 to 3 weeks after the first surgery and not immediately. The tumor markers could give us some idea whether there is any residual disease or not. Now you've done all this and there is no residual disease. So what will you do next? Any thoughts on that? Will you do a right hemicolectomy? It is a LAM. Peritoneal fluid cytology is negative. Omental biopsy is negative. Tumor markers are normal. CT scan is normal. Will you do any of this? Any answers to that?
Probably strict surveillance.
Yes, that's right. So we would follow up these patients. There is absolutely no indication of doing any kind of surgical procedure. 3 monthly tumor markers and once a year or once every 6 months CT scan is enough for these patients. So we have to understand the potential areas of spread, why these recommendations are there. For both perforated and non-perforated tumors, the incidence of lymph node metastasis is less than 5%. You would do a right hemicolectomy in any tumor to address the lymph nodes. The tumor per se can be resected with 2 or 3 or 5 centimeter margins on either side. But the reason why you perform a right hemicolectomy is to address the regional nodes. Now, this 5% is also for adenocarcinomas, LAMs, HAMs all put together. If you would see the absolute incidence in LAM, it should be much lower. I would say it should be 1 to 2% or even less. The more important thing is the peritoneal spread. For the non-perforated tumors, the incidence of peritoneal spread is only 0 to 17%. Some studies report no peritoneal spread for lambs treated with appendicectomy alone. Whereas for a perforated lamb, the incidence is between 50 to 65%. And this is another study which confirms what which actually proposed what I'm saying. Prior to the publication of this paper, whenever there was a lamb, a right hemicolectomy was performed, and it showed that for mucinous tumors, all mucinous tumors, the incidence of lymph node metastasis is only 4.2%. If you look at this survival curve, whether an appendectomy is performed or a right hemicolectomy, the survival is the same. Moving on, for a perforated lamb, again, we would do the same workup, tumor markers, CT scan, no PET CT scan for a mucinous tumor. All this is normal at the baseline. What would you do next? What if it is a PT4 lamb, a perforated lamb? Will you do a right hemicolectomy? I think not. CRS and HIPEC, yes, we would do a cytoreduction for this patient, even if the baseline tumor markers are normal and the CT scan is normal, because there is a high incidence of peritoneal spread. 50 to 65% is a high incidence. Often the tumor markers are normal, the CT scan is normal when there is minimal peritoneal disease. So this patient definitely needs consideration for CRS and HIPEC. And now we have our international guidelines, which say the same thing. If there is no perforation, no right hemicolectomy, no CRS and HIPEC. If there is a perforated tumor, no right hemicolectomy, but yes, that patient should be given consideration for CRS and HIPEC. So the next scenario is, we talked about a low-grade tumor where the epithelium was benign looking, low-grade. Now we have a high-grade appendiceal mucinous neoplasm, or a HAM. Again, the peritoneal fluid is negative, the omental biopsy is negative, and this is what it looks like. The basement membrane is intact, but you don't see any apical mucin. So that is a feature of a high-grade tumor. Cytology in HAM is high grade, invasion is pushing, it can proliferate and produce peritoneal disease. We don't know the incidence of distant metastasis because these tumors are extremely rare. It can progress to a mucinous adenocarcinoma. So a HAM is somewhere between a LAM and a mucinous carcinoma. These are the low-grade features. These are the high-grade features. Now, HAM is a relatively new term. Till 5 years ago, we were not using this term. It was previously classified as a LAM or a mucinous adenocarcinoma, depending on the classification that was used. And we are not sure of the potential for nodal metastasis, though it is presumed that it is high. It is higher than that for a LAM, and the incidence of PMP should also be higher. Again, we would do the same workup, and if we find peritoneal disease, of course, treat it. Amongst these, what would be your options? For a HAM, we prefer to do a right hemicolectomy with CRS and HIPEC, and these are the guidelines. Again, perforation or no perforation doesn't matter. Irrespective, we have to do a right hemicolectomy with CRS and HIPEC. And it is largely because of this retrospective study of 62 patients. Now, all these 62 patients had their appendix primary removed. They had post-operative imaging. There was no evidence of disease, and they were subjected to surgery. In these 41 patients with appendiceal adenocarcinoma and HAM, the incidence of peritoneal metastasis was nearly 70%. Nodal metastasis with peritoneal metastasis, 14.6%, which is very high. Nodal metastasis alone, 2.4%. And the other interesting fact in this thing is, when you look at the peritoneal disease, macroscopic and microscopic both, it was generally confined to the area of the right colon. Hence the recommendation for a right hemicolectomy to address the peritoneal and nodal disease both. The third scenario, It is a mucinous adenocarcinoma. Cytology is high-grade infiltrative invasion. It can produce peritoneal disease, rarely distant metastasis. Incidence of regional nodal metastasis is at least 5%. We do the same workup, go through the same exercise, and the treatment essentially is right hemicolectomy, CRS, and HIPEC. It is in our guidelines as well. So any questions, any comment on what's been discussed so far?
I think we will discuss at the end of this session.
Okay.
We will have question answer session. So we will discuss.
All right. All right. So we will move on to the next case. This is a 60-year-old lady with pain in the right iliac fossa. Again, CT scan shows an enlarged inflamed appendix with periappendiceal fat stranding. There is minimal free fluid in the pelvis, and this is what the laparoscopic picture looks like. This is perhaps peritoneal disease. This is the appendiceal tumor. Now, what for this case? Appendicectomy, fluid cytology, peritoneal biopsy, or send a frozen, do a right hemicolectomy directly, open or laparoscopic. You have a high suspicion of peritoneal disease in this patient. It looks like disease.
So at least fluid cytology and peritoneal biopsy, if there is suspicion of peritoneal disease, would be wise. And we can continue with laparoscopy and then base our decisions based on the final histopathology report and the cytology and peritoneal biopsy report.
Yes. So we do not prefer to do a frozen because oftentimes the grade is not correctly given on frozen. We would just do an appendectomy, fluid cytology, peritoneal biopsy. And the important thing is to document the extent of peritoneal disease, to look around the liver, around the spleen, run through the small bowel as much as possible, look at the pelvis. Now, the histopathology is again a lamb, but the peritoneal fluid shows acellular mucin. There are no cells, only inflammatory cells. You've done an omental biopsy, and that also shows acellular mucin with inflammatory cells. So we run through the same exercise, do all the baseline evaluation. Another CT scan, the tumor markers, even if they are done before the surgery, you would still do tumor markers. And in this, we would not do a right hemicolectomy because it's a lamb unless we need to clear the peritoneal disease that is around the right colon. This patient needs CRS and HIPEC. And the point I want to make here is that acellular mucin is not a benign condition, it is a malignant condition. If there is so much of acellular mucin on all peritoneal surfaces, the cells that produce the mucin are there somewhere. New studies that are coming up are showing, they are doing new studies on markers that can help you identify patients that are at greater risk of recurrence, but the treatment has to be surgery. Not treating a patient with acellular mucin with surgery would be detrimental because the patient will develop more extensive disease and it could degenerate into a high-grade tumor as well. So to summarize and give some take-home messages, for a non-perforated lamb, low incidence of peritoneal disease, low incidence of regional nodes, no right hemicolectomy, no CRS HIPEC. Perforated lamb, no right hemicolectomy, CRS and HIPEC. For a ham, both right hemicolectomy, CRS and HIPEC. Mucinous adenocarcinoma, the same. If you have any primary with acellular mucin, yes, right hemicolectomy for the high grades, or if required to obtain CC0, CRS and HIPEC for sure. Any primary with peritoneal disease with epithelial cells in it, again, right hemicolectomy for a high-grade tumor or required to obtain a CC0 and CRS and HIPEC for sure. The important thing is to get a pathology review and insist on a proper classification. If you're not satisfied, refer to a better and more reputed lab. So the last point I want to make is this very interesting paper published 15 years ago It calls the peritoneum the first line of defense. So when in the presence of peritoneal disease, you perform any non-curative procedure, for example, a right hemicolectomy, it would lead to retroperitoneal implantation of the tumor. So you see an appendiceal primary, you get a high grade, you get a high grade, let's say you've done a frozen and you get a high grade report that it's a high grade tumor, you are seeing peritoneal disease, a right hemicolectomy is required, but it should all be done in the same setting. If you do a right hemicolectomy alone in the setting of peritoneal disease, it will lead to retroperitoneal tumor implantation, and the subsequent CRS that is performed will become non-curative. So in an emergency situation, any where you've not planned a definitive surgery, it is best to do the minimum, take fluid cytology, take multiple biopsies, and leave the decision to after the pathology report is available. This is one example. This was a patient. I do not have the preoperative photographs, but she had a huge omental mass that was misdiagnosed as a splenic abscess. And she went in and had a splenectomy. Now, post splenectomy, it's been almost 4 weeks, and this is the picture. The tumor here is infiltrating the pancreas. This is the tumor around the kidney, infiltrating the perirenal fat, infiltrating the psoas. No matter how radical you are, this surgery, this patient will recur for sure. There is a high probability. So what was potentially a non-curative, was a curative surgery, has now become a non-curative surgery. So thank you for your attention. And these are my 2 books. And if you want a copy to read more about it, you can write to me on my email ID and I'll send you an ebook. Thank you.
Yeah, thank you very much, Dr. Aditi, for a clear, concise, and crisp presentation. The take-home messages were also driven home very succinctly, and I actually learned 2 or 3 things that you have to take peritoneal histology, that is one, take a mental biopsy, and perforated lamb is not as innocuous as a non-perforated lamb.
Yes.
And in case of mucinous adeno CA, you have to give a CRS and HIPEC as well.
Yes.
So thank you very much for that discussion. And Dr. Ashwin, are you ready now?
Yeah, I have a couple of fallback options. Let's hope at least these work.
Yeah, let's keep our fingers crossed and go ahead.
Are you guys able to see the screen now?
Yeah, we are able to see.
Very well said.
So we'll just hope that the video is transmitted to you smoothly. Is it
visible?
Fine.
It is visible now. Please go on.
Okay, so this is the standard port position I generally use. So this is the port position we use when there is a difficulty, there is a mass. So generally, It's always a good practice to palpate the abdomen after GA is given and the patient is light, so that we can appreciate all these early masses much better. So here you can see it is just a difficult position of the appendix. That was a pelvic appendix. This is a subhepatic appendix, but the appendix is relatively straightforward. So it is only the position of the appendix which is challenging, and clinically the pain also might be in a different area which we are used to. So here you can see this appendix is a short and a stout appendix. You do not have much of a length for us to maneuver and work through. So this is the difficulty and challenge we might face in these patients. But these are ones which we can easily tackle, and you can all manage on your own laparoscopically without much of a difficulty. So gradually I'll be taking you all to a little more difficult cases, and we'll keep increasing the difficulty as well. And here you can see this is actually a inflamed appendix secondary to a cecal growth. So we already know this is a tumor and we are taking him for a oncological procedure, but you can see how dilated the appendix are, because a lot of the times you might have heard a case scenario where the appendicitis was the suspicion, and once you go in you see a tumor. So that should not be the case. We should always be wary about all these possibilities much before. So you can see how dilated and tortuous the appendix is, and this is the area of the growth of the cecum. So that is kind of obliterating the appendix. So here you can see this is a relatively straightforward difficult appendicitis where the appendix is perforated in the somewhere in the mid body, and it is only adherent to the lateral abdominal wall. Once that adhesion is released, you can see the appendix will become straight and we can easily operate. So you can see the pus which is coming out now. And once you release it, the appendix is quite straight, and then it will be converted to a similar kind of a laparoscopic simple appendicectomy, which we would perform. So here you can see there is adhesion again to the anterior abdominal wall, and this is the pus which is present in the pouch of Douglas. So you can see the pus which is present over here very clearly. So you just suction out all the pus which is present over here, and then we will go on to the right iliac fossa. You can see the small bowel has kind of sealed off the area to confine it into a localized peritonitis rather than a generalized peritonitis. So here, this is again a very important technique of dissection in these cases. I'm using the body of the instrument rather than the tip. If you watch carefully, I don't try to push the structures with the tip. You can see the entire appendix has become gangrenous. So here again, you can see the body of the instrument is being used for traction away from the area of adhesions. So we do not go and poke with the tip. Generally, these tissues are very edematous and friable. So if we try to poke with the tip, then it would cause a lot of inadvertent injuries, which would not really ideal and conducive for us. So here again, you can see the appendix is totally gangrenous. It has gone and fused to the lateral abdominal wall. But because we are intervening early, all these adhesions are relatively easier to release without much of a difficulty. And a suction is the best instrument probably you can use in these scenarios, as long as the adhesions are not too fibrotic. So now we are trying to dissect between the appendix and the cecum so that the appendix is free on all the sides and we will have a good space available for us to dissect. So now we are going towards the base of the appendix. You can see this is the mesoappendix. It is all too friable. You can see a little bit of the base of the appendix over here. Luckily for us, that is healthy. As the previous speaker alluded to, a lot of the times, even if the entire appendix is gangrenous, this base will be healthy. And we can just apply a simple endoloop for that. But now you look automatically with the traction, it auto-amputated. So that is the amount of friable tissue we are dealing with. You can see the entire appendix is already free. So here we are just checking if there is any healthy portion of the base left for us to apply a endoloop. Luckily, we had a small portion of the base left behind. So here we are just using an endoloop, and this would end the procedure similar to a conventional laparoscopic appendicectomy, which we would perform. Albeit there was a lot of adhesions and inflammatory changes in the localized area, but not a generalized manner. So here you can see we are applying the endoloop and we are gradually tightening the endoloop so that we do not cause any cut through. So here you can see there is still a small portion left. We are giving a localized wash. Generally, we do not give any extensive wash in order to avoid pushing all these contaminated stuff below the diaphragm or into the pelvis, because this patient had a localized peritonitis. And always these cases, we use an endobag to retrieve the specimen so that we do not cause any infection to the ports. So now this is again another interesting case where you can see we are trying to locate the appendix, but the appendix is not clearly visible. So this is a typical case of a retrocecal or a retroperitoneal appendix. So here we are mobilizing the cecum. We are trying to incise the peritoneum on the lateral aspect. Here we have to be wary of the ureter. You can see the ureter very clearly. So we have to always keep it in mind. And as we use the monopolar cautery, you can see once the peritoneum is open, the carbon dioxide would enter into the plane and it will nicely dissect the avascular plane. And even thin facial structures can be made out very easily. You can see a very thin fascia over here. So that is the fascia of the retroperitoneum. So we do not try to incise it. So as we dissect, you can see now the appendix is slowly coming into our vision. Once again, we look where the ureter is present, and then we will go on further incise the peritoneum. So we should always keep the ureter in mind, and we should carry our dissection with a lot of caution in this area when we are doing the dissection close to the ureter. When we give a good traction, the abdominal wall will give us the counter traction, and the carbon dioxide will open up the planes nicely to guide us in the avascular plane, which can be easily followed. And this is the same plane which we would do for a oncological procedure like a CME as well. So here you can see the appendix is gradually becoming more and more obvious and visible. Here we are just doing a dissection in a blunt as well as a sharp manner, because these are all totally avascular planes. Once we dissect it, we can easily tease the tissues away. You can see the fascia once again of the lateral abdominal wall being teased away nicely, and we carry with our dissection. And these peritoneal attachments, only when they are released, then the appendix would be totally free and we can see the entire length. So now you can see here we are dissecting along the line of Tolt and going a little more towards the ascending colon portion as well, because the tip of the appendix was present slightly higher along the ascending colon. So here you can see now we are dissecting and releasing all these small peritoneal attachments just lateral to the appendix, so that the appendix can be freed off. And now you can see the appendix is becoming more and more obvious. So this is the cecum, and here you can see the entire body of the appendix very nicely. So this is the peritoneal attachment which is present medially. So here we should be wary of the cecal wall, and we should always keep it in the mind when we are dividing this peritoneum. So here we are using the monopolar, and we are doing that very, very close to the body of the appendix. So now you can see we are gradually changing the traction and moving closer to the tip, so that we can identify the tip clearly and dissect the tip free from the attachments present between the ascending colon and the peritoneum which is covering it. So now the tip is slowly coming into our field of view. Always use cautery in short bursts and not in a continuous manner. And we always keep the wattage of the current also very low, so that there is not too much of a smoke which is being generated. So here you can see this is the final tip of the appendix, which will become a little more clearly visible. So here as well you can see the cecum and the ascending colon very nicely. So we move well away from that and we work very, very close to the appendix. We can even work on the appendix. A small amount of cautery to the appendix is not a problem at all, because anyways we are going to remove the appendix in toto. So now you can see that is the tip which is slowly coming into position, and you can see how close to the appendix we are working, so that all these tissues are divided and teased well away. So now that is the entire tip which is coming into our vision. And once again, this is the area where the cecum is present, and you can see this is the ascending colon which is being curving, and then it will move up like that. So that is why we have to be wary, and we have to make sure that these tractions are being changed every once in a while, and then gradually bit by bit we have to do the dissection in a meticulous manner, so that we do not have any cautery thermal damage to the bowel or the cecum. That is very, very important. So here you can see again, we are just dissecting on the appendix, bang on the appendix, so that we do not have any structure. Here we have dissected and we know that there is no structure, it is only a thin peritoneum. This bluish hue is the giveaway sign that we know that there is no structure beyond it, and we can easily use the cautery without much of a worry or concern. So now you can see gradually, once we release all these peritoneal attachments, the entire appendix is starting to become free. And here you can see we have already opened up a window. This is the few attachments which is left behind. Once when released, the entire window will become free, and then the surgery will become similar to a straightforward laparoscopic appendicectomy. So once again, you can see these are the last few attachments between the tip of the appendix and the area of the ascending colon. So here again, we are working very close to the appendix, using the energy in a short burst, and then gradually releasing all the adhesions, so that the appendix becomes totally free. So now you can use an energy source if you have it. This is mainly done so that we have a good distance between the vessels, and we do not want any small vessels to bleed after retracting. We can still manage this with the conventional bipolar and scissors as well, but that will become a two-step process. So here, in order to save some time and quicken the process, we are using a energy source, but this can be done without any energy source as well. So this is a ligature. It is a sealing instrument which we are using right now. And now you can see once the adhesions are released, it's similar to a normal appendix. And here we're just applying the endoloop like how we would do it in all the cases. So now this is again another case where you can see the base of the appendix clearly, but the entire body and the tip is not visible. And you can see a lot of the small bowel which has gone and got adherent to the appendix. So once again, we use the suction, and gradually we're just trying to do a little bit of adhesiolisis in a blunt manner. We have to be very careful that we do not hold any bowel or any inflamed structures in the vicinity, because a lot of the times that trauma itself might cause some serosal injury. So even though we have a bowel grasper in our assisting hand, you can see I'm trying to just push the bowel away rather than trying to hold the bowel. And if at all we need to hold, we should try to hold the mesentery and not the bowel directly, even with a bowel grasper or an atraumatic instrument. So now once a portion of the appendix is visible, then our life becomes relatively easier because we can just start tracking the appendix and try to find the other areas. Immaterial of whether it is the tip or the base, we can still carry on with our dissection and try to identify the other areas. So now you can see a little more of the body of the appendix is becoming visible. Here you can see the area where the abscess cavity is present. You can see a little bit of the flakes secondary to the peritonitis which has occurred. You can even see some reactionary fluid in the pelvis. And so here we are just seeing a little bit of the pus starting to come into our view. So gradually we are carrying on with our dissection and trying to dissect a little more of the appendix. So now this is the lateral abdominal wall, and this is the appendix being freed from the lateral abdominal wall. All these are at various stages of inflammation because it all depends on the time when the patient is presenting and the amount of sepsis he is in that we decide to intervene, or whether we would try to go with a conservative approach right now and intervene later. So now here you can see the entire body of the appendix very, very clearly. So we are trying to dissect and do the adhesive lysis medial to the appendix as well, between the cecum and the small bowel in this area. So again, you can see with a gentle traction, we are able to open up the planes and try to do a dissection. You can see because of the use of suction to suction out the blood, the space is collapsing. So now here you can see there is a window which is already created between the appendix and the mesoappendix. So we just have to follow in the same area and try to identify the tip. So now here you can see somewhere close to the tip is the area of the pathology. So here there has been a perforation and it is all kind of sealed off by the surrounding bowel in this area. You can see this purulent kind of a mass which is present over here. And slowly we are trying to release the tip. You can see now we are just lifting off that area where the mass was present. And slowly we are just trying to release and carry on with more of our dissection. So you can see the amount of inflammatory fluid which is coming over here. So we should be very, very careful and gentle with our dissection. That is very important. And once we keep carrying on with our dissection, you can start to see that the little bit of the fecalith also will start coming into our view. That is through the perforation which has already occurred. So here you can see we're just trying to grasp only the appendix and we don't grasp anywhere else. You can see the pus coming out from that inflammatory mass which was present over here. And here we are just gradually carrying on with our dissection. So because we are using the suction intermittently, there is a loss of space on and off. And because the entire small bowel was stuck over there, until the entire adhesive lysis is done, we are going to have a very limited space. But it's not much of a concern. See here, I'm just waiting so that the gas builds up. And once again, we can carry with our dissection in a safe manner. So here you can see the fecalith, which has come out through the perforation site. So we just have to keep it in sight right now because I don't want the fecalith to contaminate. If I take the fecalith through my 5 mm instrument and if it doesn't come through, then it can break and spill over into the abdomen, which can lead to prolonged post-op paralytic ileus. Or if it comes in contact with the skin, then that port site would get infected. So I generally change the scope to a 5 mm telescope and remove the specimen and the fecalith through the 10 mm port. So here you can see we are just trying to further carry our dissection and release the entire appendix. So now you can see the tip of the appendix is gradually becoming free. And here you can see the entire body of the appendix also very clearly. So whatever the small fecalith contents which are present, we are taking it down. And here you can see the window gradually becoming larger. You can see my instrument coming out through the window. So this is what we are trying to gain. And now once this is gained, you can see the base also is present more proximally. So it is only the tip of the appendix which is still adherent. So here again, I'm using an ultrasonic energy and you can see my left hand is pushing the cecum and the small bowel away so that we do not have any potential thermal damage happening to those structures. This is again very, very important. So here you can see now the tip is becoming a little more freer, and here we have a little more additions which have to be taken down to release the entire appendix comfortably. So now we know the window where it is present. So we just have to utilize the window and keep carrying on with our dissection. Once again, we use the ultrasonic energy over here, and now my left instrument again will come and push the small bowel and cecum well away, so that we do not have any direct contact of the ultrasonic energy. Immaterial of what sophisticated energy we have to follow the principles. Otherwise, injury cannot be avoided. So here now we have a good gap between the mass and the area, and you can see these are the last few attachments which are present. Once when this is taken down, then again this will be a simple kind of a appendix where the entire appendix is visible to us, and we have to do the dissection similar to a conventional laparoscopic appendicectomy without much of a trouble. So here you can see now the entire picture is becoming more, and this is the entire appendix which has become clear. So this is the mesoappendix portion which we will divide, and once the entire portion is divided, then it will be the isolated appendix which will be left behind, and we can take it down using an endo loop similar to our conventional surgery. I'll shortly be showing you the area. So that is the base, and this is the cecum which is present as well. So I'll shortly show you the site where the perforation has occurred. So now we can show you the plane where we have to dissect. So this is the mesoappendix which is present over here. You can see the amount of smoke which is generated because of all the inflammatory tissues. So here you can see this is the site of the perforation. You can see my instrument going through the perforation. And this is the most common site of perforation which we will see in perforation appendicitis. So this is the area where the dissection has been done. You can see there is no more pus which is present. All the pus has been suctioned out. You can see the amount of space we had to dissect. So this is the fecalith which is being taken by a 10 mm claw, and we're using a 5 mm telescope right now. We make sure that the entire substance has gone into the 10 mm port. So now this is another case with a slightly delayed presentation. A lot of the times these diabetic patients, they do not have good control, and they have very good pain tolerance, and they don't really perceive pain like a normal patient. So here you can see it's a slightly delayed presentation. We knew that there was a mass, but we were hoping that it would be an early inflammatory mass. But here you can see with the nature of the adhesions, these are a little more fibrotic than the adhesions which you have been seeing so far in the other videos. You can see there is a big mass. We are not really able to see the appendix clearly. And as we keep dissecting a little more, a small portion of the appendix came into our view. So as I told you earlier, if some portion of the appendix is visible, then it makes our life easier. So now we will stay close to the appendix and try to do the adhesive lysis all around. So here you can see the small bowel and the mesentery, how adherent it is. Gradually, we are just trying to do a dissection in a blunt manner. And you can see I'm making sure that the instrument is not on the bowel and it is in the mesentery. This again is very, very important, because all these tissues are generally very friable, and it is very easy to cause a full-blown perforation or a superficial serosal tear as well. So now we are just trying to grasp the fat which was an adhesion surrounding the appendicular mass, and we're just trying to dissect between the planes. So this is the appendix area, and this is the adhesion which is densely stuck in that area. So we're just trying to create a window. So here you can see the fat very nicely, and here you can see the appendix very, very clearly. So here we're just trying to hold the fat and trying to dissect off over here. So now you will start to see the area of pathology. So this is bang on the base of the appendix, which is never a good sign, because now our decision about what to do with the site of the perforation becomes really challenging. And you can see how dense the adhesions are, and I'm gradually increasing the pressure. I'm not trying to be yanking the tissues too much, because that is not the right way to go about it. And since we stick to the right planes, you can see there is hardly any bleeding happening, even though we are doing the dissection and doing a lot of these adhesive lysis. So here again, you can start to see a little more of the pus coming into the picture. And this is the site of the perforation. So this is the cecum, this is the appendix, and you can see right on the base is the area where the perforation has occurred. So once again, our principles would remain the same. We would try to isolate the appendix all around and make sure all the important structures which we need to safeguard are dissected well away from the area of the pathology. So this is the last of the few adhesions which are present close to the appendix, which are going to be taken down. So now you can see this is the cecum very nicely, and this is the perforated side and the entire length of the appendix clearly. So here we're just pressing on this inflammatory area to see what is happening, and you can see the amount of pus which will start to pour out in this area. So you can see the pus which is pouring out once we press on the cecum. So which means still a little bit of the pus is present in that area. So now we try to dissect a little further and release all these small bowel adhesions. And now we are trying to dissect a little bit below the cecum as well and lateral to the cecum as well, so that we can do a little bit of the mobilization of the cecum so that it can be lifted off, so that our judgment about managing this case would be a little more apparent and easy for us. So once again, you can see the site of the perforation very clearly. So we are trying to grasp the tissues only below that, because all that is going to be removed with us. So here you can see this is just a sloughed out tissue which is present over here. You do not really have a healthy tissue present over there. And again, we're just trying to see if we are developing a good plane between this area so that we can carry with our dissection further. So here, this is the mesoappendix portion which is present. And here, this is the base area, and we're trying to see if there is a window below which we can go through and through, so that will aid us in dissecting a little more safely and easily as well. So here you can see the perforation is becoming more and more apparent in this area. So you can see that sloughed out tissue can be easily taken down. So now we go to the tip, and here we are going to mobilize a little bit of this lateral peritoneum so that the entire cecum can be rotated medially. So this is the other view from the opposite side. So whenever there is a lot of these tissues and oozing present, it's always a good idea to place a gauze over there. And this gauze also pushes the small bowel away from our field of dissection, so that we have additional safety, and we can use the same gauze to improve our vision as well. So here you can see a lot of the small oozed blood which is present. These generally tend to darken the image because the light will be absorbed by the blood. So when we use the gauze and wipe this away, you can see the dramatic improvement in the vision also which is happening. So here you can see we are only incising the peritoneum so as to mobilize the cecum well, so that we can decide on our plan of management, how we are going to do and how are we going to proceed further. So now you can see we just use the gauze and we wipe off that collected blood which was present over there. And now you can see the vision automatically becomes much clearer, and we have a better idea of the tissues, because laparoscopic surgery is all about the visual feedback. You do not have too much of a tactile feedback happening, but the visual feedback, the look of the tissues would tell you what type of a tissue it is and whether it is the right plane or a wrong plane. So here you can see gradually we are releasing the tissues in order to release these adhesions and mobilize the cecum a little further. So now you can see the entire appendix has become free, and now at the level of the base you saw the area where the gangrene was present. So this is the little portion of the healthy tissue which is left behind. So we leave a small cuff at the base, and then we use the energy source itself to divide the rest of the appendix. So here you can see we leave a small cuff of tissue, and we are dividing the rest of the appendix and the surrounding structures, so that we can assess the situation a little better and decide on how to proceed further. So you can see now we have removed the appendix, and this is the sloughed out tissue which is present. We're just trying to see if that tissue is coming off freely, then we will remove it. And we are also trying to assess how deep the slough and the gangrene is going. So here you can see there is some amount of pus which is coming out in this area. And you can even see that is the opening which is leading on into the cecum also, which is very clearly seen, because we wanted to drain all this pus out. See, now we are pressing on the outside in the cecum, and you can see the entire pus which is coming out through the opening. And once that is over, this tissue was healthy. So we thought we will just do a intracorporeal suture closure of this opening. And then we will just let the body take care of the other course and let it heal well. So here we wanted to do a interrupted suturing rather than a continuous one, because this being a edematous tissue, once the edema settles down, if it is a continuous suture, there is a high probability that the suture will not be approximating the tissues well. So here we're using an interrupted sutures, and you can see how deep and thick wall we are taking in a bite so that we do not have any cut through which is happening. And you can see the instrument being protected from the small bowel which was present as well. So now we are going to do good surgeon's knot in a square manner, and you can see that the traction is not going to be throttling the tissues, whereas it's only going to be gently approximating the tissues. This is also a key which we have to keep in our minds. So now this is the first surgeon's throw which we are doing, and you can see already the tissue is coming close together, and gradually we are going to increase the tension on the suture so that it is approximated watertight. So you can see there is no cut through happening, and we are handling the tissue in a very gentlest manner possible, because we want it to hold and not cause more damage than which is already present. So now you can start to see the opening very nicely, and you can also decide on the amount of sutures we require for a good approximation. And here again we are using the sutures, and you can see that this is the second bite which we have taken. So second bite is taken through and through because we have already mobilized the cecum a little bit. We know that it is safe and without much of a difficulty. And this is the third bite which we are taking, and you can see we are all taking all these needle under control so that we have a good approximation and we do not cause any additional injury. And because the omentum was freely available, we also take a bite in the omentum and kind of plunge it to the area of the cecum. So this is similar to a DU perf kind of a picture which we would do. So this would be the last case which I'll be presenting. This was a young boy who was referred to us with the diagnosis of a perforated appendicitis. In ultrasound scan, there was air under diaphragm and there was a lot of rigidity. And you can see inside a lot of peritonitis flakes which were present. Gradually, we are releasing the adhesions, and to our surprise, when we went to the RAF, the appendix was totally normal. So now the next diagnosis which we should keep in mind in these cases is to go look at the duodenum. Unfortunately, the duodenum also was normal. So then we decided that we will check at the small bowel. The entire small bowel was examined, and gradually we are doing a bowel walk. And here you can see the area of pathology. So basically, this is the Meckel's diverticulum. And here you can see there is a perforation which has happened in the base of the Meckel. So here you can appreciate the entire Meckel's. And we have done a lap assisted surgery in this patient. You can see how long the Meckel's is. This is the site of the perforation, very clearly visible to us. So this is the fan and steel incision through which we did the resection anastomosis. I take this opportunity to welcome you all to the IAGS National Conference to be held at Coimbatore in May. It is going to be the first on-site conference post-COVID disruption. I'll be very happy to welcome you all to the conference. Thank you very much for your patient listening. I'll be happy to take any questions you guys might have in this presentation. Thank you very much.
Thank you, Dr. Ashwin. That was indeed very lucid and a very impressive presentation. You drove home the points very clearly, and in each complicated situations, you provided clear-cut answers to the challenges that we face. Madam, should we open the forum for questions and discussions for another 10-15 minutes, maybe? Dr. Nina Bam, are you there? Okay, so I invite all the questions. The questions can be typed in the chat box, and I will take them one by one. So let me begin with a question that has come up from Dr. Dilip to Dr. Ashwin. How do you deal with friable base of the appendix? I think you've answered that, but you would you mind reiterating it again? And can we diagnose Crohn's disease while doing lap appendicectomy? Dr. Ashwin.
Diagnosing Crohn's disease while doing lap appendicectomy might be very difficult, because a lot of the time the presentation would be similar to any inflammatory appendicitis which we would look at. So that might be really challenging. With regards to the question about the base of the appendix, the ideal way is, if you have a space and a tissue which is available in a healthy manner, then suturing it would be the easiest option which we can do, because even stapling in an edematous tissue is not very easy, and it's going to be very difficult. If the tissues are not too healthy, then the two options we have is, if you feel there is no direct communication, we can just place a drain in that area and come, or to be in a little more safer side, to do something like a tube cecostomy.
Okay, any other questions? I don't know whether the participants can unmute and ask the questions, but continue to type them in chat box, and I will. So someone has asked about the port positions. How about the umbilical and two suprapubic ports, like they do in Dr. Palanivelu's unit? Dr. Prabal, can you answer this question? I think we have discussed this, but still, Dr. Prabal, is he there, or Dr. Prabal?
Talked about that earlier on. Probably what they are doing is, I'm not sure, I haven't seen it, but probably what they're doing is that put the supra pubic port, they put the camera through that, and one is at the left iliac fossa and the other right iliac fossa. Is that right? I think that's the.
I think they put the camera in the suprapubic position, 10 mm port, and then operate through umbilical and right iliac fossa.
Umbilical and right iliac fossa port.
Yeah, so that gives a good triangulation. That is an option. Of course, like the port positions do vary with the surgeon's technique. Port position, Dr. Balasubramanian is asking port side, the port positions in case of difficult appendix or appendiculomas. I think Dr. Ashwin has already elaborated on that. Would you again repeat it, Dr. Ashwin?
Yeah, sure. So in cases whenever we have a mass, and we always try to keep the camera as much away from the area of problem. So RIF is our target area. So we would try to put the camera port a little more lateral to the umbilicus, around 4 centimeters lateral to the umbilicus in the same umbilical line. If it is not too much of a big mass, it's only a little difficulty which you're anticipating, then you can put the camera port in the left iliac fossa as well and perform the surgery without much of a difficulty.
Okay. So, question to Dr. Niyogi from Dr. Rakesh Makwana. Your comments regarding stumpitis and stump appendicectomy. That is the first question, and then Dr. Aditi has to answer one more question. So,
Right.
Dr. Niyogi, yeah.
Yeah. As I'll reiterate again. The keeping the stump at 5 millimeter, I think, is the ideal. What longer stump and basically necrosis between the two ties in the appendix, that is the problem. So keep it minimal. So say about 5 millimeter. You should not have this Douglas syndrome or stumpitis.
Yeah.
No, but I will modify this question. That if someone has done appendicectomy and now patient comes to you with the stumpitis, or it is a stump is there and patient is having pain, when will you operate after the first surgery?
Ma'am, I have done a few patients in which the stump and was there, just like gallbladder, which comes up again. You have to redo it. Sometimes you need to redo it with patients when they come with symptoms of appendicitis and the stump is large. It is a problem, but we'll have to do that then in that case.
Okay.
Dr. Rakesh Makwana has also asked Dr. Aditi that textbook does not recommend, Mango's textbook does not recommend lap appendicectomy for appendiceal mucinous neoplasm because of risk of spillage and dissemination. Your comments, please.
So I think laparoscopic appendicectomy is safe, provided you do not hamper the peritoneum unless you are planning a definitive procedure. Like I said before, do not attempt any definitive surgery like a right hemicolectomy, or do not attempt to do a partial peritonectomy. Otherwise, laparoscopic appendectomy is absolutely safe. I don't think intraop spillage is a concern. So I don't know. I'm not read Mango recently. I don't know why that recommendation is coming from, but none of our guidelines or there is no paper that says that laparoscopic appendectomy increases the risk of peritoneal dissemination. Regarding the couple of other questions, where to take a peritoneal biopsy. So in case you don't see any disease, if you see some disease or suspicion of disease, of course, you would biopsy that area. Otherwise, one omental biopsy and one biopsy from the right paracolic gutter or the right iliac fossa. That would be the right place to biopsy because that is the site which will be involved first in case of peritoneal dissemination.
Yeah. And I think when we are doing laparoscopic appendectomy for mucosal of the appendix,
Yes.
it is safe not to rupture the tumor. So handling of the appendix has to be done at the area where it is normal, or there is no mucinous component.
Correct. And usually these tumors are in the body or the tip. You will
Yeah.
rarely find a tumor that is involving the base. If there is such a large tumor where you cannot get a free margin, probably your pathology will show a perforated lamp. There will be mucin and cells outside. So as it is, a second procedure will probably be required for those patients.
So when it is more than 5 centimeter, it is to be converted to the open or directly taken as a open surgery as per the recommendation, because you cannot remove 5 centimeter size dilated appendix from your 10 mm pot, and that is the main indication for that. Yeah.
Okay.
So there is another question, whether can you use titanium clips for ligating mesoappendix? Dr. Ashwin, I'm sure you can use Liga clips, but what about titanium clips?
We can use, provided the mesoappendix is that thin. If you actually have a clear indicated case of appendicitis, generally the mesoappendix would be quite edematous, and all these vessels will be very small. They will tend to, retract and bleed at a later time. So in thin mesoappendix, you can. Theoretically as well, you can. But the ideal way, if at all you're looking at some ligation, would be to either apply an endoloop or do a ligation.
And what about the appendix itself? Can you use Liga clips for the appendix itself?
Yeah, actually, the paper which doctor had earlier talked about, Dr. Negi, it had compared even usage of hemolock, titanium clips, staplers, endoloops, everything. So all this can be done, provided the approximation is good enough. But if you ask me whether it is recommended to just use the titanium clip, definitely not. Yeah,
here I would like to add that often we use staplers with something, as a luxury or a technique or a tool which is beyond our reach, but it can be helpful in situations where there is inflamed base of the appendix but a healthy cecum, and that would give a secure closure. And that has to be kept in mind in suitable cases, as we discussed. It is not that we can't use them. Dr. Mukesh is asking, base ligation with catgut or vicryl or silk, advantage and disadvantages of each, single loop or double loop. Dr. Ashwin, Dr. Nyogi, you can take that question.
Regarding the type of suture, I don't think there is any difference in whether you use a catgut or any absorbable suture, which is long lasting, vicryl or catgut. I don't think there's any difference in use of both. Regarding the other question, what was the other question?
Single loop or double loop?
Single loop or double loop, yeah.
Single loop or double loop. Now, see, that depends on whether you have got a good control in the first loop that you have taken. If you got a good control, if you think you're all right, I think one is enough. But if suppose it is very edematous at the base and you think that one loop would not be sufficient to be doubly secure, get the first loop slightly not so tight so that doesn't cut through, and you can put another one on top of that and then cut above it. So that depends on case to case. There is no recommendation as such if it should be one or two.
Just a word of caution is when we're using a double loop, always make sure that the second loop is not too farther away from the first loop. A lot of the times what happens is they leave a stump, they put a second loop, again a small stump before you cut it, and that is the reason you tend to have a lot of these stump appendicitis. So it should be around 3-4 mm and not more than that.
I personally never put a double loop. It's just one is enough. One, do it securely, that should be fine. You don't have to put two.
So I have one question for Dr. Prabhu.
Yes,
if you are operating a planned appendicectomy or if you are operating in an emergency appendicectomy, once you insert the pot, what are the indications for immediately converting that patient to the open appendicectomy?
That again depends on the surgical skills of the person who's operating. Suppose it's an
Yes,
emergency, most of the time it's the residents who are doing it. So if that is a problem, I think they should convert right away. But if it's an experienced surgeon in an elective setup who's operating with all the gadgets that are there towards thing, I don't think there should be any case which cannot be operated. Rarely there are some cases which nearly, unless it is of course a malignancy, as Dr. Aditi said, if you mucinous carcinoma, if there's doubt, then in that case you might have to take, as is very clearly elucidated by her, take biopsies or to take cytoreductive surgeries.
And which conditions we will go for retrograde?
Madam,
Junior
sometimes,
surgeon. I am asking these questions particularly for those junior surgeons. Yeah.
yes. Sometimes in which when there is like not everybody is as skilled as the surgeon as Dr. Ashwin. Sometimes what happens is that when you are not able to get to it's a large, huge appendix which is tightly adherent to the cecal wall, and you're not able to take the body of the appendix out, get control of the mesoappendix, and you can see the base which is clearly visible. Then you can put a right angle through it and take, just like an open, if you can do it, and take the base out, secure it, and then gradually tease the appendix out from the cecal wall if it's badly adherent. Again, very careful of energy sources near the cecal wall. So again, as reiterated by earlier speakers, the use of the suction cannula is the best acting instrument to do it, and of course with energy devices.
I think if there are no further, are there any further questions? I can't see any in the chat box. If there are no further questions, madam, should we close the session?
Yeah.
Yeah, so thank you all the speakers. It was a wonderful session, a lot of learning happening there. I personally thank Dr. Neena Shah, Dr. Dhaivat Vaishnav to have spared their Sunday time and chaired this session. And thank you speakers, Dr. Prabol, Dr. Ashwin, Dr. Aditi, for all that you had discussed and all that learning that happened on this forum. Thank you very much.
I have a message from Dr. PRM, Pankaj Bhai, that because of some emergency, he was stuck somewhere. So he is not able to join this. Sorry for him. Yeah. Thank you, every speaker. Yeah.
And thank you very much, the Ahmedabad Club. You're doing a great job, and I think I enjoyed it as much as you all did. Thank you so much for the invitation.
Thank you.
Thank you, all the speakers. Thank you.
Thank you so much.
Thank you.